Thank you for that introduction. That's really generous. And I want to say, I understand that many of you in the room are centrally involved in curriculum development and education here at Mount Sinai. It's a real privilege to speak with you. Actually, Mount Sinai has long been a place that I admired for its innovations, particularly the medical humanities program, medical humanities track. And more recently, I've been perhaps in this room, or at least in a room that looked like it, to speak with your health and social justice group, which is really inspiring. So it's just such a privilege to be here. So today I'm going to be giving you an overview of an approach that I and my co-author, Jonathan Metzl, called structural competency. So he too is jointly trained in medicine, and in his case, cultural history, in my case, cultural anthropology. What we saw was an opening, and I'll get into this in more depth, but an opening in medical training and practice to start looking above the level of the individual doctor-patient encounter to community organizations, non-health sector institutions, public policy makers that we can collaborate with as clinicians to improve our patients' health. And I think that's going to be really key to addressing health inequalities going forward. I'll go into that in more depth in just a moment. So the outlining of this talk is going to be really 4 topics. My starting point, and Jonathan's, I believe, was the idea of structural competency that has really taken off in medical education over the past 2 decades. In general, that's a move in the right direction in looking at health inequalities, but we think that there's something missing, and that's what I'm going to be explaining in the course of talking about structural competency. The second topic, I want to explain a little bit about the background of our use of the term structure as opposed to culture, even though the two are intimately related, and some might argue the same thing. So I'm going to be talking about social determinants of mental health. I'm using mental health as an example throughout, although it applies well beyond mental health to physical health of all kinds. But I'm a psychiatrist, so a lot of my examples from my own work come from mental health. And structural violence as a concept that I think can be very useful. I'm importing it from the social sciences into clinical practice to understand why institutions are such an important place to look for addressing health inequalities. The third topic is structure. How do we begin to think about structures as units of intervention, as opposed to individual doctor-patient encounters? And the last topic is competency. How can we put intervention at structural levels into practice? I'll try to be brief here because I do want to have time for questions, but I began to be curious in the course of this work about the history of the idea of cultural competency. And there aren't a whole lot of official histories of it, but the furthest back that I see reference to, at least the precursors to cultural competency, is in the 1950s and 60s medical sociology literature, where medical sociologists began to study the quote-unquote culture of biomedicine. They began to study medical students and how they become acculturated into medical practice. So there was a growing awareness of medicine, biomedicine as itself as a cultural system that people can adopt and move into, and something that can be distinct from the culture of patients that come through the clinic doors. And then the next place where cultural competency actually comes into circulation as a term is in education research in the 1970s. So the concern there was with educational disparities. Why were, for example, African American, Latino, and Native American students so far behind other groups in terms of educational attainments? And education researchers began to look at cultural systems in ways that educational institutions could address them more effectively to promote educational achievements. And that language was then adopted into medicine in the 80s and 90s. So organizations like the AAMC and ACGME that regulate medical schools and residency programs, they began to adopt the term cultural competency from education as a way of looking at health disparities in particular. And a number of different approaches came out of that. I'm going to just highlight 2 ends of a spectrum that I've distilled from the literature. One is an approach that I call cultural expertise, where the objective is really to impart as much information to clinical trainees as possible about specific cultural groups. And it's often broken down by ethnicity and race, although gender and sexual orientation, religion, other factors can play in. But the idea is to get practitioners up to speed on cultural beliefs, cultural groups, their beliefs and practices, how that intersects with clinical practice. And out of that movement has come something called cultural consultation. McGill in Canada, in Montreal, has been kind of a leader in that, but the idea is that if you have a Senegalese patient and you're struggling to establish rapport and understand that patient's challenges, you can call a cultural expert that has a background in Senegalese culture. And then on the other end of the spectrum are those that argue that what you really need is, and these folks come out of the humanities, medical humanities, what you really need is an approach for understanding each patient in terms of their cultural context. So cultural sensitivity kind of that highlights that it's more of a process. It's not a knowledge base that you have to get under your belt. It's an approach to a patient where the patient becomes a partner in cross-cultural understanding. And within psychiatry, you may know about the DSM, the Diagnostic and Statistical Manual that we use for diagnosis. And in the 90s, after the DSM-3 came out with no reference really to culture or those sorts of inequalities, Arthur Kleinman, Juan Mezich, Arthur Kleinman being a psychiatrist, medical anthropologist, Juan Mezich, who was then head of the World Psychiatric Association, they lobbied for inclusion of an appendix in the DSM-4 that took into consideration culture-bound syndromes, an approach called cultural formulation to eliciting a patient's cultural beliefs and practices. So that's kind of how it played out in psychiatric practice. And just to get back to what the motivation was for all of this cultural competence activity, this is a report that Surgeon General Satcher put out in 1999, and we still cite it. It was kind of this landmark document that pointed to really big inequalities in mental health care and mental health outcomes. And as a result, all of us in mental health know these statistics that African American men are 4 to 8 times as likely to be diagnosed with schizophrenia as white men. Suicide is 4 times as high among Native Americans as among white Americans. Recent Chinese immigrants will often stay out of the mental health system until the very, very last moment to get any care. So these are the kinds of inequalities that the report put into popular circulation. A lot of the discourse coming out of that had to do with cultural competence as a way to have clinical practitioners take patients' cultural beliefs and practices into account and engage them in treatment as a way to reduce disparities. And so this is kind of a foreshadowing of the concept that I'm going to be introducing, because my argument is really that we can't separate culture as discrete beliefs and practices from the structures, the communities, the institutions, the policies within patients have to navigate. And so by structure, I'm really referring to community organizations, health-relevant sectors such as non-health sectors. We typically don't think of schools as part of our healthcare system, but in fact, they're extremely relevant. Housing organizations, law enforcement and corrections, urban planning, just to give a few examples of very health-relevant sectors that we don't often formally engage with. And then public policy is, of course, really important. All right, so this is my argument for why culture is also structure. The risk of making patients' beliefs and behaviors, cultural practices, the focus of our interventions to reduce inequalities is that we might be attributing health inequalities to their cultural beliefs and practices. You know, that's kind of a logical inference that isn't made explicit, but it's there, unless it's directly kind of questioned. And that's something that I call cultural determinism. And it comes close to a concept of culture of poverty that was in circulation in the 60s and 70s, that it's essentially poor people contribute to their poverty through their beliefs and behaviors. And that's actually not where we want to be in our clinical interventions. So I think that if we step back and include institutions and structures in our definition of culture, realizing that culture, even if you're thinking of beliefs and practices, are interactive with the community structures that people are in, the institutions that they engage with, and we see cultures as dynamic, we can avoid stereotyping people into groups and attributing their health outcomes to their beliefs. So that's really my argument, that culture is shaped by and shapes institutions and political economic conditions. These are structural factors. And then we shouldn't forget that our own medical clinical practices are also structures, and that the culture of medicine is a powerful determinant of health. So we constantly have to be looking at our own role in this as a structure that's relevant to health. But we naturalize our own our own beliefs and practices as clinicians. And then competency. Competency I pair with structural because it really highlights the professional expertise that we as clinicians bring. But if we are trapped in an idea of culture as something bounded and static, that it's the beliefs and behaviors of a patient kind of divorced from the context that the patient lives in, then we give up the opportunity to employ collaborative models and address the context that patients live in. And so I'm really going to be arguing at bottom for social change as a form of health promotion. I have here mental health, but it's broader than that. This is just a schematic to highlight what I mean by static bounded cultures. So this is the way that some of the cultural competency literature, especially early on, tended to refer to cultural groups. That we have black culture, you have white culture, they don't really interact, and they're kind of there for all time. This begins to come closer to the way that I'm arguing we should see culture, and this is influenced by my training in anthropology, that what we observe as black culture or white culture is heavily influenced by things like school systems, housing policies, including racial segregation, mass incarceration and law enforcement practices, the media and how these two groups are represented. And just as an example, thinking about that statistic of schizophrenia in black men that I gave, that they're 4 to 8 times as likely as white men to be diagnosed with schizophrenia. Without a picture like this, you may think, oh, well, it has something to do either with their biology, they may be biologically predisposed to schizophrenia, or maybe it's their belief system. There's something about black culture or biology that is responsible for these higher diagnostic rates, when in fact there's so many different structures that impinge on diagnosis. So one might be that black men living in poverty are subject to a lot of stressors that can make them more vulnerable to certain symptoms. Another could be the ways that clinicians interact with black men as opposed to men from other groups. And there may be, in the context of diagnosis, some misinterpretation of symptoms and some attribution to psychosis that may not belong. And then there are things that, such as what I study, disability law, right? That often I work at Bellevue, where we are trying to get people Social Security benefits. What is one of the most effective ways to get them disability benefits? Give them a diagnosis of a chronic, severe mental illness. Schizophrenia is an especially effective one. So that's well motivated, but it also can help explain the disparities in diagnosis. So that's just an example of all the kinds of contextual structural factors that may play in. And without this context, we, again, may be misattributing these inequalities, the cause of these inequalities. This is a slide that goes even further to show how I, as an anthropologist, see the world. There really aren't boundaries, so to speak. These things are constantly interacting, these policies, community structures, and individual diagnoses. So just a quick review of the ways that some of my colleagues have addressed what they saw as the deficits of a classical cultural competency approach. One approach is cultural humility. I wonder how many of you heard of Melanie Tervalon and Jean-Marie Garcia's cultural humility concept? No? A couple of people. Okay, that's great. So this came out over a decade ago. But really what they were arguing was that we have to pay attention to the power imbalances in doctor-patient encounters and not come into the encounter with the attitude of omniscience. So our job is not to know everything about the patient without talking to the patient. Our job is to engage with the patient, make the care patient-centered. But they go a step beyond that and talk about equity in healthcare requiring also community collaborations. So it's a power imbalance not only between doctor and patient, but also if you're talking about low-income ethnic minority communities, particularly community collaboration and community empowerment is going to be necessary to really influence health inequalities. And this is an alternative that my friends Beth Bromley and Joel Braslow at UCLA put out. This is an article they had in the American Journal of Psychiatry about critical thinking as an objective in clinical education. And what they're really talking about, I love the term critical thinking because it can be embraced by everyone. You know, it's really appealing to a wide range of people. But what they're really talking about here is the culture of medicine. They're saying we have to be much more self-aware of what we bring into the interaction. Power imbalances is a big part of it. Yes, self-awareness. So this takes on the other end of our own contribution to structural inequalities. So I should give a little background to this. I'm just going to give you an example from my own research. A lot of my work lately has been on addiction pharmaceuticals in the effort to mainstream addiction treatment into primary care. And one of my findings as I have gone along in this project is this really stark race and class disparity in who's getting buprenorphine, a newer opioid maintenance medication, versus who's getting methadone. So this is a slide from the only nationally representative study that was done, showing here, 91% of buprenorphine patients nationally were white, only 53% of methadone patients nationally were white. Here's another revealing statistic that 58% of those entering buprenorphine treatment are employed at baseline versus 29% of those on methadone. So that gives you some feeling. So just being faced with the statistics, you might not know what's responsible for this. Perhaps white patients have a preference for buprenorphine over black patients. Perhaps college-educated patients have a preference for buprenorphine. It's not really clear. Beliefs and practices first come into mind. This is an image from a website sponsored by buprenorphine's manufacturer. It's a prescriber matching service. So you can go online, type in your zip code, find a prescriber. The vast majority of the prescribers, particularly in New York City, are private sector doctors, private practitioners. And you can also see from the imagery on the website who they were really pitching this product to. So this is just a prompt for me to say in my own research, I've been documenting structural factors such as marketing, such as the legal and regulatory structures. For instance, the requirement that physicians that prescribe buprenorphine be certified to prescribe buprenorphine. They have to go through an 8-hour training. It's actually the only pharmaceutical that requires that kind of additional training for certification. And it discourages public sector doctors because they don't have the same incentive to get certified. So that's just an example of the kinds of structural factors that may be hidden in statistics about disparities. Okay, so I'm going to get back to my theoretical frame. These are a few ways of thinking about structure that can be useful in moving in this direction of enabling clinicians to intervene on structures. One is a knowledge base and social determinants of health. I keep referring to those really when I talk about health inequalities. The second is the concept of structural violence, which may be less familiar to clinicians, and structural racism, very intimately tied to structural racism. And then the third is individualism of clinical mental health. Here I say, throughout, I have mental health, but I really want to emphasize that this applies broadly to health, and the literature bears that out, that there's an individualism embedded in our own cultural system by medicine. That we're going to have to overcome if we want to be aware of opportunities to intervene on structures. Okay, so what are social determinants? My guess is that many of you in the room are familiar with the concept of social determinants of health. I'm going to lay out one definition, elements of the social environment outside of direct clinical care, outside of the doctor-patient encounter, that cause positive or negative health outcomes. And these are really powerful correlates of mental health, also physical health. They're visible on the population level. They're much easier to see when you compare populations than when you look at individual cases. Although when you're taking care of an individual patient, if you dig enough and get a history from them, understand their context, you can see evidence of structures and how they impinge on care and outcomes. So this is a 2013 Institute of Medicine report that came out in the news because it reported that the US, compared to 17 peer countries in terms of income and development, came out on the bottom in terms of health outcomes, but actually came out on the top in terms of health expenditure. Is everyone here familiar with this report? Did you all see it? Yeah. It didn't have as much coverage as I would have wanted it to, but it was out there. So everyone wanted to know why this tremendous statistic. And the report really honed in on structural factors. So they pointed to healthcare systems, the fact that we don't have universal healthcare access. That was an obvious one. They talked about health behaviors, but they talked in terms of behaviors such as drug abuse, traffic accidents, firearms, that all had structural correlates with state and federal policies, drug policy, for example, firearm policy. And then, so they're also structural. And then social and economic conditions broadly, they pointed to the fact that the United States has higher level of poverty than its peer countries and higher levels of inequality. And they detailed how that played out in terms of health outcomes. And then physical environments, lack of public walkable space, lack of access to fresh produce within walking distance, these sorts of factors. And then here's another population-based study that highlighted the role of social determinants of health. This is a mental health example, but an entire book was written by these co-authors, Richard Wilkinson and Kate Pickett. They are UK-based epidemiologists that compared countries in terms of an index of inequality. And what they found was that the countries that had higher levels of inequality generally had poorer health outcomes. That was physical and mental health. You can see the USA is on the extreme of both social inequality and poor health outcomes. The real punchline from this study was that the wealthiest quartile of the most unequal countries, such as the US, the life expectancy for people in the wealthiest quartile was lower than the life expectancy for people in the wealthiest quartile of more equal countries. So the punchline was that inequality is bad even for the rich, and hence the title of their book, The Spirit Level. Okay, so if we turn back to race as one example of an inequality, there's been some amount of research on racism and how it's embodied as a way of looking at health inequalities. And I'll give you an example from people in my field of anthropology who studied, for example, skin color and hypertension as mediated by the HPA axis, stress hormone system. And they found that darker skin correlated with hypertension and HPA activation in the US, but not in West Africa and parts of Brazil where skin color didn't have the same social implications for ability to advance, likelihood of poverty, et cetera. And then, and I just make a note that it's less clear because there isn't as much research how this relates to mental health outcomes, but HPA axis is also involved in emotional dysregulation and mental function. So we can definitely see a potential mechanism there. So that's one area, that's individual racism, face-to-face racism. Another level that I really want to hone in on today is institutional racism. So by that I mean, for example, discriminatory public policies. I'm interested in addiction and drug policy. The disparities in law enforcement by neighborhood are really well documented. So that means it may not be an issue of individual face-to-face discrimination. It may be an issue of, for example, where you live and drug policy where law enforcement takes place. And then residential segregation. I'm going to give an example of that in a moment too, but racial residential segregation in the US is also a strong correlate of health outcomes. You may have heard that, that sound bite that your zip code is more predictive of your health than your genetic code. So a lot of our racial practices in this country are geographically bound, not necessarily visible on the individual level. And I'm just giving a quick shout out here to Nancy Krieger at Harvard School of Public Health, who developed the ecosocial theory. She's been drawing on this kind of research to highlight how social environments are embodied. And she really highlights that this happens at many levels. So from face-to-face racism to institutional racism. And these levels of influence interact with each other to influence how often people are exposed to assaults on their health, how susceptible they are as individuals, how much resistance they have to poor health. So I promised an example of institutional racism through housing segregation. This is a map of Philadelphia, and it's actually from 1934. It's a bank mortgage lending map. And I wonder how many people in the room have heard of redlining as a practice. Is that something that you've been familiar with? Actually, a good number of you. So this is a practice that has happened on the part of banks and mortgage lenders for over 100 years. The idea is that the quality of housing stock, and therefore the likelihood that a bank will lend a mortgage loan, is determined by, in large part, the ethnic composition of the neighborhood. So the less white the neighborhood, the more likely the neighborhood was to be ranked in the red, poor lending risk. So the implications that this has had over the generations for ethnic racial inequalities is that poverty has been concentrated in those neighborhoods where people could not own homes, get mortgages to own homes. Because in the US, most people hold their wealth in their homes. And that had intergenerational effects. That means that families in neighborhoods of low home ownership could not send kids to college with that funding, could not weather emergencies, family emergencies. They had fewer resources to keep up the quality of the neighborhood as a whole, to keep up public space. And so we see, even to this day, that these red lines map over areas of concentrated poverties in US cities. And this practice was outlawed in 1974, but it actually persists. My husband and I actually got involved in a class action lawsuit against a mortgage lender that it turns out had given higher interest rates to African American and Latino clients. So it's powerful, but it was followed by a couple of other policies, urban renewal, planned shrinkage, that was especially active in New York City a couple decades ago, in which neighborhoods were disinvested, often razed and dislocated. And that kind of dislocated shredded the few community resources that were there because the networks were shredded as a result. So I'm just giving you an example of a real structural determinant of health. The health impact well documented by my mentor and colleague, Mindy Fullilove, among many others. I'm going to get back to her example. But well documented relationship to, for example, HIV infection rates in these cities around dislocation. And this is just a little reminder to me, as well as others, of why it's important to speak with clinicians and focus on clinical practice. Because we could ask ourselves, what does this have to do with me? There's a whole school of public health up the street, perhaps not in Mount Sinai's case, but in many cases, there's a school of public health that is supposed to be taking care of this. And I want to argue that actually we have a critical role and a critical opportunity opening up in front of us as clinicians. So I've made this argument that inequalities are driven by these social determinants, inequalities in health. The other point is that we as doctors are getting really frustrated by the structures that we're up against that challenge our ability to provide good care. This was from a few years ago, a Robert Wood Johnson funded study that 80% of physicians surveyed said that social causes of disease among their patients are really important, but they have no idea what to do about it. They feel really hamstrung. They don't have the skill set. And what we're seeing in the literature is more and more physicians leaving practice and other clinicians leaving practice because of burnout related to these structural factors. And that's causing in psychiatry a big crisis. I think it's also applicable to primary care and internal medicine that people are leaving practice. They're very frustrated by structural factors. And yet we have this opportunity opening up in front of us, the Affordable Care Act, which actually calls on clinicians to work toward population-level measurable health improvements and reductions in inequalities. Okay, so on that theme of structural intervention, I want to introduce structural violence as a concept that could put even a little bit more fuel under us. And it's one that I borrow from social science. It was first introduced by Norwegian sociologist and founder of peace research as a discipline, Johan Galtung, in 1969. And what he was looking for was a way to make visible the ways that lives and productivity are lost as a result of violence, the violence of social exclusions and institutions, oppressive institutions, as opposed to more visible wartime injuries. So he was making the argument that people die and definitely people suffer as a result of things that happen on an institutional level that we don't see in the way of person-to-person combat or violence, interpersonal violence. And then Paul Farmer picked up on this concept 30 years later. You may have heard of him, physician anthropologist who does a lot of global health advocacy work. So he's been using this term to talk about suffering such as in his whole global health work, he's seeing the ways that people are dying of HIV and multi-drug resistant tuberculosis as a result of national policies, international policies, where we invest our money, not only in terms of healthcare systems, but water systems, transportation systems. So he's making a strong argument for structural violence in global health as a place to intervene. And why might structural violence as a concept help us? One, it again focuses us on institutions and policies. So social determinants, the word social is kind of diffuse. It's kind of hard to pinpoint. It's just social. Whereas structural implies that there are specific institutions and organizations that we can look to and policies for change. And then the second is that violence kind of holds us accountable. Determinants may sound a little bit immutable. You know, these are determined, there's not much we can do. Whereas if violence is involved, then this is my third point. First of all, it's very urgent. You know, it calls us in. People are dying, people are really suffering as a result of it, so it's an urgent need. And it's an action that we can intervene on. Okay, and so that gets me back to structural competency and why I'm advocating for this language shift as a way of leading into shift in practices. So we get to look at structures, and we also get to look at our interventions. So competency goes beyond awareness to what are we actually doing as clinicians. And we have a lot to offer. So as clinicians, we have symbolic capital. People, you know, when it comes to health issues, people's ears perk up when they hear someone who's actually a practitioner talk. Also, we have social capital, and we know a lot of decision makers in healthcare and health administrators. We have the clinical knowledge that we can bring to bear. So we have a lot that we can offer. I want to highlight in partnership with other disciplines, since we don't have in our clinical training usually a lot of knowledge about how organizations work or how public policies work. So we have to partner with people who do. And this is just a quick list of a foreshadowing of the ways that clinicians and clinics can cultivate a health-promoting social context. We can work toward integrated community-based care, inclusion of housing and social conditions in health interventions. We can collaborate with community organizations, schools, law enforcement, parks and rec. We can address chronic trauma and violence in poor neighborhoods. We can advocate for health-promoting public policies like housing law, drug law, education, and employment. These are health issues. And that's the approach that we've taken with, when I say we, I'm talking not only about Jonathan Metzl and myself, but a growing group of clinical educators and advocates, multidisciplinary advocates that are rallying around structural competency. We've had 3 national conferences. This is the flyer from our first one. We have some webinars coming out on the topic of structural competency. The most recent was SUNY Albany ran a series. And before that, the American Medical Students Association. And we have a couple of special issues coming out on structural competency. So it's something that we're trying to get out into the ether. We're not alone in focusing on social determinants of health. I think what we have to offer here is a language to put, especially when it comes to clinical practitioners. And this is the paper that we wrote kind of laying out the theoretical framework for this. And I'm drawing on the paper here where I talk about the specific competencies that we should be injecting into clinical education. One is recognizing the structures that shape clinical interactions. So the first step is just to even see structures. The way that we generally treat patients and describe patients in case reports doesn't necessarily include the context that the patient is coming from and the structural barriers to their care. So the first step is to put that into the way that we look at patients and describe them to each other. And that gets to the second point of re-articulating cultural presentations in structural terms. So in thinking about disparities, starting to, when we present cases, describe the structural factors that may get in the way of their healthcare or facilitate their healthcare. I'm going to go over the second 2 in a moment. Observing and practicing structural intervention is really important. That's critical, and that's kind of where I'm putting my efforts right now. There aren't enough opportunities for trainees to do that, to put this into practice, get their hands into it. And then the last is developing structural humility. That means learning how to work collaboratively with people from other disciplines and community members, for example. I want to give a case to flesh this out from my own practice. So this is RUBEN, who I saw in the Bellevue Chemical Dependency Program. 57-year-old, comes in from the Bellevue Men's Shelter, has been taking heroin for 20 years, goes on to methadone. And then because he has such negative interactions with the methadone staff, he is eventually shifted over to buprenorphine, because Bellevue actually has a buprenorphine service that people with Medicaid can take advantage of. It has for a while. And he seemed to do really well on buprenorphine, as well as a group of therapy groups that he settled into. Now, the irritability that he showed with the staff, that was diagnosed as a feature of bipolar disorder by his psychiatrist. He was put on mood stabilizers. He also applied for Social Security benefits on the basis of that, and he got it. And then IOP is for Intensive Outpatient Program. He graduated from that program, which involved a lot of group therapies and counseling. And on graduation, this was 3 years into his treatment, the staff noticed he was skipping doses of buprenorphine. He was starting to buy opioids on the street, opioid pills. And on the face of it, you may say, okay, this is a classic case of chronic relapsing brain disease. You know, addiction is a relapsing disorder. We know that it's really common. That's what's happening here. Or you might attribute it to his lack of motivation to change. Okay, and so what we did as a staff was we did a rereading in terms of structure. So the Social Security benefits that he got through the clinic had provided him with transitional housing in Brownsville, Brooklyn. And that was a real source of stability for him. He'd been homeless for quite a while, so that was a stabilizing force. Before I go into that, what happened right around his graduation from the addictions program was that his housing, it turns out, was illegal. It was not registered as transitional housing. Brownsville, Brooklyn, by the way, has a huge number of these illegal transitional housing programs. And I see some of you nodding. It's a part of the healthcare crisis, the housing crisis in New York City. Landlords, opportunistic landlords, will rent out a few floors of a building, cram 10 people to a floor with 1 bathroom for the building, and get a part of their Social Security check each month. So it's a lucrative industry. He was in one of those, and it got shut down by the fire marshal. So he was out on the street again. He was homeless again. Second thing is that art therapy in the intensive outpatient program had been a real source of support for him. It had helped him to gain a new identity as an artist and a leadership position with other clients that he became an art instructor for. So it was this social milieu was really important, and he lost that when he was kicked out of his housing. I think I talked about this. Another factor that came into play is that he couldn't fill his buprenorphine prescriptions after graduation. He had been getting buprenorphine from the hospital pharmacy, and after his discharge from the intensive program, he had to go to outside pharmacies, who it turns out often didn't have it in stock and didn't want to have it in stock, would not order it. It turns out that some pharmacies out there don't want the clientele of opioid-dependent people. This is the problem we were able to identify and lodge some complaints around. And then insurance authorization was another structural barrier. His insurance plan, after discharge, put up a lot of barriers to him getting access to buprenorphine, and that delayed his refills. So once we were able to identify these structural factors, we were able to act. We were able to get the housing specialist on the case. It took a year, but he did get legal housing, subsidized housing eventually. We were able to find an outsider art studio that he could join to support his identity as an artist. And the pharmacy refill issue is continuously a problem, but at least we've brought that to the attention of the right authorities, and we hope that that will change over time. So that's just an example of how a case can be reread in structural terms and open up new opportunities for intervention. And then I want to get to the second 2 competencies. One is observing and practicing structural intervention. And that's the hardest part of this, I think. It's one thing to give lectures on social determinants of health, and I think more and more medical schools are doing that. They're starting to put social determinants of health as a larger part of their curriculum. But then the question is, what do clinicians do about it? That really is the hardest thing, because up until now, clinical practice hasn't been oriented to structural intervention. And that means that we don't have enough faculty who do that kind of work. We don't have enough programs that are oriented to structural intervention so that clinical trainees can really work on it. And then the last part is, as a part of that, developing structural humility, collaborative work with people from other disciplines. So I'm going to give a few examples from around the country of structural interventions that trainees are a part of. And I really, in my mind, break these up into a few different levels of structures. So the easiest, I think, to implement in clinical training is what you can do in the clinic. And so For example, electronic medical records. I have a couple of colleagues at UCSF, Laura Gottlieb and Nancy Adler. I see I have a little bit, not much time left, so I'll try to make this brief. But in their studies of electronic medical record systems that implement prompts for assessments of social needs in the patient interviews, what they found is that by prompting clinicians in the EMR to ask about social needs, such as housing, such as food stability, or food access, they're seeing more social services being integrated into the treatment plan. So just that intervention has had an impact on what the treatment plan includes. And then medical legal partnerships, how many people here are familiar with that as an intervention? A few people? It's more and more medical schools are doing this, where medical practitioners are paired with, and often trainees, are paired with legal trainees and legal partners to advocate for patients where it comes to, for example, evictions and cases against landlords, lead poisoning cases, for example. And so this is a growing movement to pair lawyers with doctors, essentially, and legal trainees with medical trainees. Health Leads is another example. It's an organization that pairs volunteers that are often medical students with clinical practitioners so that patients, these volunteers help patients to fill prescriptions that their clinicians write for things like housing, or this is really taken off in pediatrics, for example, learning disability assessments. So the volunteer will help the patient to navigate through to get those needs met. This is the next level, community partnerships. But it's a really powerful place for clinicians to be working. That is looking outside of the 4 clinic walls to community organizations that can help to address known needs among their patient population. This is the Brownsville Partnership. It's an organization I've been working with to launch an elective for psychiatry residents in a neighborhood that has the highest concentration of public housing in the country, as it turns out, a very high level of interpersonal violence and exposure to trauma, and a lot of mental health problems as a result. This partnership started out as a housing partnership, but it's grown to become a broader-based cultural community development project. And what they did was they found that mental health problems were getting in the way of people taking advantage of the programs that were there for clients. They reached out to our psychiatry residency program for help. And so we were able to send, now we've sent 7 residents there as part of an elective to do community-based mental health interventions. And these are just a few examples. One is, they started with psychiatric screening and psychoeducation in community programs and also in homes. They went to home visits as part of multidisciplinary teams, looking at people who are at risk for eviction and what their mental health needs might be. Then they conducted a community mental health needs assessment that was used to develop a wellness center that the partnership built. And there the community said they had a real need for crisis intervention and youth programs. So youth programs as a mental health preventive measure to keep people out of gangs and off of the street. So that's where they started with the wellness center. Another thing that the residents did was that they trained peer leaders in support groups that are trauma-focused, bereavement groups for people who've lost family members due to trauma, due to violence. Right now, they're engaged in basically hotspotting of health service needs and health service resources in the community. So figuring out how to link needs with resources by mapping those, literally using Medicaid data, service utilization data, and interviews with local providers. So they're learning to look at a structural level at where the needs are and where the resources are. And I'll just flash through. These are some maps that the team put together with Medicaid data showing Brownsville is an area of high mental health cost, an area of high substance use disorder cost. It's 80% African American and 17% Latino. So in terms of the geography of health disparities, it's a classic example. I'll go to the next level of structural intervention, which is across sectors. The Brownsville Partnership actually is an example of collaboration with non-health sector agencies. One of the most important partners that we've found in Brownsville so far is with probation, so with criminal justice, just in enhancing the communication between probation officers and healthcare providers. We've been able to divert some arrests and divert mental health hospitalizations. Because probation officers were seeing their clients decompensate, but didn't know who to reach out to or what to do. Another example of cross-sector collaboration, this is Mindy Fully-Love, who I mentioned earlier, who studies racial residential segregation in US cities and ties them to poor mental health outcomes and physical health outcomes like HIV infection. So her latest project is to reintegrate US cities in collaboration with urban planners and architects. And she's made a lot of progress in test sites such as Pittsburgh, Orange, New Jersey, and Roanoke, Virginia. These are a couple of books that she's written about it. The most recent, Urban Alchemy, is really about how to reintegrate cities in partnership with urban planners. So she's really taking the unit of intervention as not the patient. She's a psychiatrist by training, so she's an MD, but rather than treating individual patients, she likes to say that she's treating cities in collaboration with people who have the expertise that's needed for that. So that's a health intervention, treating cities. This is where I spend time on drug war policies. The disparities due to law enforcement practices in light of US drug policy are pretty widely known. And this is a partnership that I'm excited about because it's given me a way to provide trainees with experience doing policy advocacy work. Punishment to Public Health is an organization that was founded by a group of mental health practitioners, physical health practitioners, public health researchers, law enforcement officials that were disenchanted with a system that was incarcerating a lot of mentally ill people, people with addictions, and also people with an incarceration history themselves are in this partnership. And what this has done is many of the trainees that I work with, students, fellows, and residents, have been trained to advocate in different places, city, state level, for policy change, to divert people from the criminal justice system to the mental health system. They've also been involved in a number of local projects, such as a project in the subway system to screen and treat people who would have otherwise been arrested on the subway system for mental health problems. So a lot of arrests have been diverted that way through this project in partnership with the MTA. All right, so now I'm wrapping up. The tasks, I think, for structural competency going forward involve identifying the key social determinants of health that should be the focus of our intervention as clinicians. And some of that might involve in-clinic assessments, kind of looking at charts and looking at the pattern. If you're treating a specific patient population, I know here at Mount Sinai, you treat a lot of people from Harlem, no? And so that could involve looking at patients from specific communities and looking at their presentation for a pattern, a structural pattern. What are the sorts of things, structural barriers that get in the way of their health care and their health in general? Then the next step is training medical practitioners to implement interventions. And that's the part that I think is going to require more legwork, reaching out to partners. So the Brownsville Partnership, for example, has a number of community organizers, housing specialists, people from other disciplines. And that's where the value added has been in having psychiatry residents to work with people with that kind of experience. So they get a completely different perspective and they learn how to draw on the skill set of people from other disciplines. Another is clinical partnerships with community organizations and health relevant sectors and agencies. I described, for example, our communication with the probation office in Brownsville and how that helped to identify people who otherwise might have been rearrested or hospitalized early to get them mental health care. And then the last is enhancing the role of medical practitioners in crafting public policy. I don't think that's out of our reach. I think a lot of what's been missing in the public discourse has been the perspective of healthcare providers who really know how policies are going to play out on the ground. So I think that by having much more experience in clinic with structural interventions, we as clinicians will gain a consciousness of the way that our experience and perspective as practitioners can speak to policy making. So that's kind of my ultimate goal for this. And then some thoughts based on my experience working on structural competency interventions so far is that structural change requires persistence and patience. It really takes time because you're talking about whole institutions and changing practices at the institutional level. It's really important to offer positive examples along the way as encouragement, because I think that we as educators can do more damage than good if we leave people with the sense that this is overwhelming, that social determinants of health are just so huge, and there's really not much we can do as individuals to address that. If we present the statistics on disparities in health without presenting really concrete examples of what clinicians can do about them, I think we can discourage our trainees and our practitioners. So it's really important to offer positive examples. And then, the benefit of it is that this is something that we can do to get more satisfaction out of our work, because it's an action that we can take to improve our patients' health and to push back against the barriers to our good health care. So this is what we want to get out of it. It's good for us as well as our patients. Third is collaboration and interdisciplinarity are required. So that means that we have to identify and work with new partners in this kind of work, maybe even urban planners and architects. Those aren't groups that when I started medical school, that I thought I'd be wanting to collaborate with, but they can be handy. It depends on the question and the problem at hand. And then hands-on programs and supervision outside of the clinic. That's where I am now, developing more partnerships like the Brownsville Partnership, where we can give clinical trainees opportunities to work insight on structural interventions and get a new perspective as a result, and work with people from other disciplines and see some results coming out of that. So I think I'll end there because I want to leave some time for questions. Thank you.